MedCircle, how are you? Let me know in the comment section below. Good, bad, right there in the middle. I'm doing great today. Part of the reason I'm doing so great is because I'm so excited about who our guest is for this live stream video. If you're a MedCircle member, you've probably seen a number of his series at medcircle.com, or perhaps you've seen him right here on YouTube. We're going to be joined in just a little bit by psychiatrist Dr. Domenick Sportelli. Dr. Dom and I have worked together for years, and I'm so excited for him to be back on the platform talking about a really critical topic in the mental health space, and that is misdiagnoses. Misdiagnoses, incredibly prevalent. According to a recent study from, let me pull it up here, National Institute of Health, some cases, it's between 50 and 70% of cases are getting misdiagnosed. And of course, with a misdiagnosis, that can often lead down a less than perfect treatment protocol. If you have not registered for our free event on May 22nd, please do. You can register for free using the descriptions in the bottom of this video, or you can go to medcircle.com and register. We typically only have these live workshops for our paying members, but because it is Mental Health Awareness Month, you can access this free live workshop just by presenting your email address. And if you can't make it live, all good. We'll send you the replay. Just send us your email so we know who to send it to. That, again, is in the description of this video. Can't wait to see you there on May 22nd. Now, enough about me. Let's bring in the man who is the reason you're all here, Dr. Domenick Sportelli. Dr. Dom, fabulous to see you.
So great to see you, Kyle. As usual, incredibly excited to be on MedCircle with you tonight. And I think it's even more exciting when it's live, right? Because we get to answer questions and interact with the MedCircle community, which is incredibly cool.
Yes, we have Melanie and Sherry, who were here early, already starting the chat off. Thank you both for being here. And of course, if you have any comments or questions for Dr. Dom, put those in the chat. My first question for you, Dr. Dom, is talk to us on why it's so critical that we get a correct diagnosis in mental health.
Yeah, so here we go. So diagnosis in mental health is critically important, right? Because this is the facts, right? That when we're looking to treat something, we have to know what we're treating, because things will be treated differently. Different diagnoses will be treated differently on multiple fronts, right? So psychiatry and psychology is incredibly complex. Sometimes, Kyle, and to the viewers out there, sometimes I wish that all I had to do was take out an appendix and be a surgeon, because it would be much easier to diagnose an appendicitis with an X-ray and an MRI and then do the surgery and remove it. Psychiatry and psychology, behavioral health is unbelievably complex. So our forefathers in psychological health and behavioral health came up with the Diagnostic and Statistical Manual. I'm almost positive that MedCircle viewers are pretty aware of that, but that's sort of the book that we use to assist us with diagnoses. And the reason for that is pretty simple. Number one, it's how we communicate to our patients and to other doctors and other practitioners, because we need to know that we're talking about the same thing, that there's consistency. So that's incredibly important. That's why we have that. But honestly, we need some form of structured classification and diagnosis to guide logical decisions about treatment and intervention, right? How can we make logical decisions if we don't specifically know what we're treating? And the third part of that, and I'm making this very simple, but the third part of that is, the DSM is not just some slapped together list of syndromes, right? And I want everyone to know that it's far from perfect. And as a psychiatrist, guys, I'm telling you that it's far, far, far from perfect. And, I'm probably one of its biggest critics, and we could talk about that. But we need that to guide treatment based on research. This is based on research and epidemiology, meaning that there are hundreds and hundreds of statisticians and psychiatrists, psychologists, social workers, pediatricians, neurodevelopmental specialists that are on the work groups to develop the DSM internationally, by the way, not just in the United States, but internationally, to really make sure that everyone's on the same page with regard to how these diagnoses look. And I'm going to add another thing. We know it's imperfect. And one way to tell you that it's imperfect is because it's been evolving since it started. Mm-hmm. So the DSM-1 was way, way, way back. The DSM-2 and 3, like 1980s. DSM-4 up until 2013. So now we're in the DSM-5. But just that should tell you that as we learn more about neuroscience, genetics, the different diseases, how it's been monitored, we have to change it because we're still learning. And you know what, guys, I've said this before, mental health is like the final frontier of medicine. We're scratching at the surface of understanding a lot. So we need the DSM as a foundation. Again, far from perfect, but we need it in order to make logical decisions moving forward with who we're treating and how we're treating those people based on empirical evidence. So that kind of sums that up.
What would you say are the most commonly misdiagnosed disorders in the DSM?
Yeah, there are quite a bit, right? And when you look at statistics about misdiagnosis, and you quoted some things in the beginning of this YouTube live, but the affective disorders are very highly misdiagnosed. Affective disorders meaning mood disorders. Number one, I think takes the cake, is bipolar disorder being very, very, very misdiagnosed.
Being misdiagnosed. So just to clarify, Dr. Dom, it's being diagnosed when the person doesn't have bipolar disorder, or people with bipolar disorder are being diagnosed with something else?
Yeah, no, sorry. Yeah, to clarify what I just said, people that have bipolar disorder, true bipolar disorder, are not being diagnosed correctly. And they're being diagnosed with other things, potentially major depressive disorder, attention deficit disorder, post-traumatic stress disorder, and anxiety disorder, maybe even a psychosis, maybe even a primary psychosis. It does go the other way too, not to complicate things, but sometimes we do miss bipolar disorder. But sometimes people that truly have bipolar disorder, it kind of goes both ways. So sometimes even somebody with a major depressive disorder with psychotic features, for example. And again, I don't want to get too much into the weeds, but it does go both ways. But usually it's a missed diagnosis, meaning we're not picking up on the true bipolarity.
Yeah. I'm clearly the farthest thing from a doctor, but I've interviewed a lot of doctors, and you and I sat down for hours to do multiple discussions on bipolar disorder. And it is so shocking to me that could be overseen or misdiagnosed, because the way it was explained to me was actually so clear. Maybe Mandy or Wade, we can link to that bipolar series in the description of this video in case people want to see it. But what role then would a patient have if they go in to see a psychiatrist and they go, look, doctor, what you're telling me is not in line with what the research I've done? How do you have that conversation?
Yeah, I love it. And I think this is such an important conversation. I'm so glad you're bringing this up. So first of all, I'm going to say something that might ruffle some feathers of some ruffle some feathers of some behavioral healthcare providers out there, but that's fine. Good. Let's ruffle some feathers. I think that any provider, psychiatrist, psychologist, social worker, therapist, whoever they are, if you truly believe that the DSM is the ultimate end-all be-all Bible of diagnoses, and that people fit perfectly into those categories, well, then you know what? Then either you're naive, you're idealistic, you're ignorant, maybe you're arrogant because you have too much of an ego. So I'm throwing all this out there. So as practitioners, we need to be humble and know that every single person is unique, and they might fit a large majority of some of those symptom complexes, and it could sort of lead us down a really good path for treatment, but it might not be perfect. So that being said, what you just asked was, how does someone talk to their doctor? How does someone talk to their clinician? How does someone even bring up, hey, I think I might be misdiagnosed? Well, my first bit of advice is that if you go to your doctor after a thorough evaluation and you just don't feel like they got it, you're like, I don't know, it doesn't make sense. I've been reading about this. It doesn't seem to fit. If you approach your clinician, provider, doctor, and say, doc, I've been doing some reading. I know myself and I'm experiencing these symptoms. I think they're really important to talk about because could it possibly be something else? Or did we miss something? In a very conversational way. If your doctor or practitioner says, absolutely not, no way, this is what it is, done, see ya, then you know what? You have the wrong doctor.
Yeah,
I think that you have to have an open mind. And I tell my patients this all the time. I say, here's the truth, is you know you better than I know you.
Mhm.
You know you better than I know you. Having a 90-minute conversation for an intro psychiatric diagnostic sort of discussion is just that. It's an introduction, right?
Yeah.
It's an introduction to try and help understand what's going on in your life that's making your life difficult, and to see if we could see patterns and syndromes and recognize if you truly have an impairment behaviorally that we can help you with. So, I encourage individuals to advocate for themselves wholeheartedly. I encourage individuals to research and read. And yeah, that's a little tricky because I know Dr. Google is tough sometimes and can really kind of send you off the rails. But obviously, MedCircle is a great, reputable place to do that. Watch videos and listen to clinicians and doctors. Anyway, advocate for yourself. And if you feel that something is off, have the conversation with your provider. If they shut you down, big red flag.
Yeah. That's one of my favorite things about working on MedCircle is the amount of people who find value in getting the right diagnosis because they come into the doctor's office educated. Or they get a diagnosis and then they go watch the series or attend a workshop and they either go, yep, that you nailed it, doc. That was exactly it. Or they go, now, wait a minute, this doesn't feel right. Why did I get this diagnosis? And they can come informed and educated to ask those questions. Where it gets more complex, Dr. Dom, I think, is when we have co-occurring disorders. And by the way, everyone, I see your questions, love them. We are going to get to some of those here in just a little bit. But we have co-occurring disorders. How does that impact the misdiagnosis rate or chance for misdiagnosis?
Tremendously.
Okay.
It impacts it tremendously. And I'll tell you why. So a co-occurring can mean a few different things depending on, what we're speaking of. Co-occurring can mean multiple diagnoses at once, and that could be anything. That could be, let's make it really complicated. Let's say someone has true bipolar disorder, bipolar 1, but they also have personality disorder. So that could be considered co-occurring, right? Or multiple diagnoses. For the most part, when doctors and clinicians talk about co-occurring or dual diagnosis, we talk about substance dependence and substance abuse associated with a primary psychiatric diagnosis. And that's unbelievably challenging because it's quite obvious. If someone's abusing substances, it's altering neurochemistry incredibly. And you're going to get a biased picture when you interview someone or see them and what's happening in their life at the time. Now, I'm a very, very strong believer that although there's an incredibly strong genetic component to addiction, and there is, right? And that has to do with, dopamine reward systems in certain people and affinity for certain substances like alcohol or opiates, whatnot. So there's a genetic component, but there's a reason why they're using. And in a lot of cases, it's self-medication because they're suffering somehow, whether it's a history of trauma, whether it's an underlying depression or anxiety, whether it's an underlying fear or phobia. I just treated a girl in the hospital who had an incredible social phobia, but she would drink an enormous amount of alcohol every day because it helped her deal with people.
Yeah.
Right. But to get back to your question without getting too tangential, it's really hard to diagnose someone when they're actively using a substance, maybe for self-medication, because you're not getting a clear picture as to the underlying circumstance. So what we always recommend, even though we can treat things concurrently, we can certainly treat someone with an addiction and a primary psychiatric diagnosis, but we have to be really careful and we have to really dig into history. You have to really dig into history, your childhood, your past, before you were drinking or using substances. What was going on in your life?
What about familial history?
So when we're doing a psychiatric diagnosis or an intake, very, very, very thorough, and it's very important. So the first thing that we do is what's called an HPI, history of your present illness. So those are the basic open-ended questions. So what brings you in? What's going on? What is your subjective experience that you're having trouble with? When did it start? How long has it been going on? So all of the specifics about what that individual is subjectively experiencing, right, which is incredibly important. Timing, onset, duration, triggers, precipitating factors, all of these things are very important. But we have to continue down that questioning to medical history, right? Medical history is unbelievably important. Kyle, I've had people that had adrenal tumors that made them seem manic, or people that had hypothyroidism that made them lethargic and want to sleep all day and were misdiagnosed as depressed.
Wow.
So medical history is unbelievably important. Medicines and over-the-counter medicines that people are on, because medicines, even heart medicines, diuretics, blood pressure medicines, all of these things can make you feel not so great. Maybe make you feel manic, like corticosteroids, or maybe make you feel lethargic, like some of the antihypertensives or blood pressure. So medicines that you're on in medical history. And then, as you just said, familial history. Family history is important in a few reasons, right? For a few reasons. One, because we undoubtedly know that there are psychiatric and behavioral health implications that are genetically inherited. Like, we know that undoubtedly, that bipolar disorder and schizophrenia and even certain depressive syndromes, anxiety, we're seeing genetic links, right? So it's important in that way because it might guide us down a path. But the other way it might guide us down a path is if your family members, or you grew up in a household with someone that was schizophrenic or bipolar or with severe anxiety, maybe that affected you psychosocially. Maybe you witnessed some things growing up that sort of led you to this. If you had a mother that was incredibly anxious and guarded and protecting you and, all these things, that can affect you down the line of how you perceive the world, right? So family history is very important, not only for genetics, but also to understand the dynamic of the family structure when you were growing up. So yes, so family history is important. Social history is incredibly important. Collateral information, meaning, if you allow us to talk to your other doctors, if you allow us to talk to your family members, your spouse, your significant other, your partner, it's all great information. So, family history, social history, medical history, all of this is unbelievably important. And even then, it's a work in progress. So, if a patient says to me after their first session, Dr. Dom, what is it? What's my diagnosis? Because, there are people like that just need some sort of closure. They're like,
oh, that is 100% me.
Like, what is this? I need it treated. Yeah. I need the black and white. What is it? What medicine's going to help me? Right? And I'll tell you why that is. I mean, the theoretics behind it is that, as humans, we like control. And when we feel out of control and we feel powerless.
Yeah.
So if something's not going right in our life, we're like, give me an answer here, please. Right.
Yeah.
So if a patient says that to me, my answer is usually pretty similar. It's, well, this is kind of where I think we're going with this. And so far, this is kind of my working diagnosis. And this is how I think we should treat this. But let's look at some other avenues too. Don't forget, let's just throw out anxiety, right? Let's just say someone comes to my office and says, Doc, I'm a nervous wreck. Okay. Incredibly vague, right? So we really have to dig. And with everything I just said, all that list of stuff, the medical history and family history and all that, sometimes people will still just be like, I don't know why. I'm just nervous. I'm nervous all the time. All right, triggers, what's happening in your life? I don't know, Doc, I'm just nervous. So it makes it really challenging. Of course, we can say, okay, sounds like generalized anxiety disorder, right? All right, so maybe we're working down that path of a generalized anxiety disorder. But guess what? When I see these patients more, when we're talking with the therapist, when they're talking with the therapist, just this morning, I've been working with a patient for months with an anxiety disorder. And just this morning, we started talking about how living with her parents, because she's in a divorce situation, she's living with her parents, how incredibly anxiety provoking that is, because it makes her feel like a child again. And they're very judgmental and critical. And it's like these big light bulbs go off. And the reason that that's important is because it's going to facilitate treatment, right? I can give you a pill that might take your anxiety down, that might stabilize your mood, that might assist with maybe delusional thinking, or maybe assist with feeling very sad and down. But Kyle, hopefully you guys know me by now. If you're not getting to the root of the problem, you're going to go in circles, right? So my long-winded point, I hope I'm not being too tangential here, is that diagnoses are hard to come by. And even though people want a specific diagnosis quickly, I think it's a work in progress. And the more you learn about somebody, the more that you're going to dial that in. Yeah. And it takes time sometimes, it just takes a little bit of time.
That was one of the first things that I was taught when I joined MedCircle, was that the importance of the correct diagnosis is to inform the correct path for treatment. But so often somebody fits part of a diagnosis. Perhaps they, reach some criteria for depression, but not all of it, or they reach some criteria for a personality disorder and not all of it. And so at the end of the day, we're really treating symptoms more than, in my opinion, symptoms more than like a disorder in some cases. And Bart de Haas has a question related to this, or I believe it's related to this. His question is, would you agree with psychiatrists like Dutchman Jim von Oss, who argues that since many disorders require the same treatment, wouldn't it be better to describe psychological variation? Dr. Dom, your thoughts?
Yeah, so it's a great question. It's an excellent question. I love it. You're thinking this is very, very important. It's very important to think, right? But I'm sorry, making like, but it's a wonderful question. It's an excellent question, and it's an important question. So, all right, the issue with psychiatry and behavioral health, or one issue with it, which I wish was better, is that our treatments are very broad. Our treatments are very broad when it comes to psychopharmacology. So let's say someone is presenting with an affective disorder in the form of a depressive type syndrome. So absolutely positively, it could be a major depressive disorder. It could be grieving. It could be major depressive disorder with a psychotic phenomenon. It could be a bipolar disorder in a depressed phase. It could be anxiety that's causing you to feel helpless and hopeless with pieces of depression. And what ends up happening is, as psychiatrists, we look at the bulk of the symptoms and we say, okay, it might not fit all these criteria, but I do think potentially this medicine might help. So an SSRI, for example, I know they're prescribed readily for, mood disorders, right? Depression, anxiety. So we would start something like an SSRI, but I think even more important than that is understanding the nuance, as I said before, of what the precipitating factors were, right? What the perpetuating factors, why it continues, what your triggers are, what your family life is like, what your psychosocial circumstances are like. So yes, we're going to dial in what's causing your depression and the little nuances of depression. And sure, we could probably put a pretty tight label on it after getting to know you for months and months. But the pharmacologic treatment is probably going to be pretty similar across depressive spectrums. Where your point comes in, the individual's point comes in, is probably with psychotherapeutic intervention. Because I think the psychotherapy would be more tailored to someone, let's just say that their anxiety or sadness or helplessness and hopelessness is caused by a traumatic experience, for example. You're going to tailor the psychotherapy to that, right? If it's a fear or phobia, desensitization training, if it's depression because of an existential crisis, you're going to tailor your psychotherapy to that. So the smaller nuances that we figure out over time, I think, can be much more tailored to psychotherapeutic intervention for really good benefit. Unfortunately, our psychopharmacology is pretty basic. It's pretty basic and sort of covers a lot. I hope that answers your question.
Yeah, I appreciate that. I was curious about that question as well. We've talked a little bit about how misdiagnoses, how to avoid a misdiagnosis, but how do we know when we have the correct one where we go, yeah, this is good. Awesome.
Well, that's tough. And you know why it's tough? Because we're biased. We're in our own head.
Who, the doctor or the patient?
Well, probably both.
Yeah.
Probably both. So that was great. Good clarification. Probably both. You hope, and I work really, really hard every day to not be biased and be as objective as I can, right? Very, very important for a clinician to be that. But as patients, we're very biased because, listen, I'm using myself as a patient. I've had struggles with some psychiatric issues myself, right? So we're biased. We think we know what's going on in there, and we think we know what's going to help us, or things like that. Now, again, in the beginning of this conversation, I said you better than anyone, right? Yeah. But it is very important to have an objective outsider sort of look at things and maybe kind of open your eyes to things that you might not see. So how do you know if you have the right diagnosis? Well, I'm going to simplify it. Hope it's not overly simplistic. But if it feels as though you're being heard, if it feels as though your symptoms are being addressed, and if it feels as though the treatment is working, then I think you're probably pretty close to
Mm-hmm.
a good diagnosis. I would, and I hope that's not too vague, but it's really what we have, and really good communication with your provider throughout the entire treatment process. Remember, it makes me nuts. All my pet peeves, right? I'm kind of venting here. I apologize, but it kind of makes me nuts. Like if somebody goes to their family doctor and they check a bunch of lists on what's called a PHQ-9, and this patient's depressed. Here's an antidepressant. See ya.
Yep.
Okay. Well, all right. Well, maybe your depression will alleviate a little bit. Maybe your anxiety will alleviate a bit. But are we really addressing what's going on here? You really need continued follow-up. So, for example, as a psychiatrist, we'll say, hey, this looks like a depressive syndrome. Doesn't really look like a mania or bipolar disorder. Doesn't really look like a psychosis. Doesn't really look like a trauma. Let's start you on a little bit of antidepressant medicine. But you better believe we're going to follow up in 2 weeks.
Yeah.
And then we're going to follow up 2 weeks to a month after that. And then we're going to follow up after that. And again, as I said, a work in progress, right? How are you feeling? Is anything getting better? Tell me about your week. Tell me about your month. Tell me about the ups and downs. Tell me about your symptoms. What's going on with sleep? What's going on with appetite? How are your thoughts? All of these things are so it's an ongoing process. Behavioral health is not, I have high blood pressure, so I was prescribed a blood pressure medicine and now I'm good.
Right.
It's just not that. It's not that.
I know that.
Right?
For sure. Let's see. Someone had a good comment here. Sherry's Jubilee says, your doctor works for you and you can fire them. I agreed.
He's right. He's right. Yeah. No, this person's absolutely correct.
Yeah.
We
forget that.
Yeah, of course. And man, oh my goodness, I can't tell you guys how many times I hear stories about people with horror stories about, their providers. They didn't listen. They were arrogant. They only spent 5 minutes with me.
Mm-hmm.
They blew me off. They didn't address my circumstances. And I say, you know what? You got the wrong doc. You got to move on. You got to get somebody else, get a second opinion, get a third opinion. The trouble with that though, and I feel terrible sometimes because I know that there's a shortage of behavioral health providers, right? So if someone comes to me and says, oh my God, my psychiatrist, my therapist, my psychologist doesn't have, it's not working out. And I say, well, you got to find somebody else. They roll their eyes at me and say, doc, do you know how hard it is to get a behavioral health provider right now, let alone a good one? Right.
Yeah.
I could speak to that a little bit. The good news is, I'm a associate program director for a training program, and we're training a lot more psychiatrists. So we're really trying to fill that gap. And and
that's why I really applaud the primary care physicians who just by default are often having to step into the behavioral health space for any number of reasons. And I understand, the ideal would be to see somebody who specializes in whatever symptomology you're experiencing. But that's, if you're in a medical desert and you got that one person, then that's who you got. And, I think for the most part, they do the best they can. And, thumbs up for them.
We call them the front line, they're on the front lines of medicine, right?
Yeah.
And they're kind of like the frontline providers. So we do need it. We do need it, but we really need specialists too, because
I know.
Behavioral health is really nuanced.
Yeah, no question. I've gotten the best results when I've seen somebody who really was narrowed into what I was seeking rather than having a general understanding. If you're watching this, thank you for watching so long. I appreciate that. I'm going to ask for 2 favors here from you, okay? The first one is if you can hit that little thumbs up button, it helps us. And it helps a variety of things, but it helps grow this YouTube channel. And we've grown it over 5 years to 1.5 million people. We reach millions of people a month. That's something we're very proud of. And it's largely in part thanks to your support. So thank you for supporting the channel. The second thing, as a thank you for hitting that thumbs up, we have a free workshop that we rarely ever do. Typically, these are only for paying members. You can access that free workshop using the link in the description. If you cannot attend the live workshop live, all good. We'll send you the replay. If you're watching this after May 22nd and the workshop has already aired, submit your email. We'll send you the replay so you can see it. It's going to feature Dr. Ramani talking about difficult personalities and relationships. It's going to feature Dr. Christy Lamb, psychiatrist out of Southern California, on stress, anxiety, and burnout in the workplace. and triple board certified forensic and neuropsychologist, Dr. Judy Ho, who will be going through exercises and techniques around inner child work as it relates to healing trauma from childhood. It's jam-packed with a lot of mental health resources, insight, and advice. You again can register using the descriptions below this video. Dr. Dom, we are at time, but I would love to give you the floor to talk about anything you haven't talked about or any final thoughts on misdiagnoses.
Yeah, I think just in summary, mental health is tough. As I said, being a provider in this field, I like to say, you probably heard me say this before, Kyle, that although our diagnostic manual is like the primary colors, people are like the Benjamin Moore color wheel. Hundreds and hundreds and hundreds of mixes and matches and shades. And we really try to get as close as we can with diagnosis to ultimately treat and provide the best care. That's our goal. But be open and honest with your doctor, maintain really good line of communication with your provider. And if you feel that something isn't right, advocate for yourself. There are a lot of reasons that people don't tell their doctor everything. Some of it is shame. Some of it is fear of judgment. Some of it is just hard to talk about, right? Whether it's your substance use or your childhood trauma history or a million other things that might be really hard. But just know that the more information that we have, the better diagnosis we can make.
Yeah.
So definitely I encourage you to try and be as open and honest and in a confidential, safe space with the appropriate provider. And, and go from there. But it's not a perfect science. So advocate for yourself and, definitely speak up if you feel like something's not right.
Yeah. Honesty. Therapy is powerful. Honesty in therapy, life-changing. Amen to that, Dr. Dom. Lovely to see you, Dr. Dom. You always put a smile on my face. I'm so glad that we could have you back on our platform.
Same.
Awesome. Awesome. And thank you for watching this. I hope that this week is going great for you. I hope there's some cool, exciting things in your life happening for you. I know that there's struggles out there and obstacles, but I hope in the middle of all that, there's also some cool stuff going on that you can think of and enjoy. I'm Kyle Kittleson. Remember, whatever you're going through, you got this.